Honorable Chairperson, respected judges, and learned audience, Assalamu alaikum. I am Dr. Umme Habiba Ferdaushi, presenting my topic. My topic is septal or apical pacing. ECG can unveil the enigma. We all know pacemaker is an amazing and life-saving device, and these two person, they are the cardiac surgeon and as well as engineer. They first made the handmade implantable pacemaker, and this is the person Larson. He is the patient to whom first pacemaker implantation done. So for today's presentation, I selected 3 of our cases. Our first case, he is a patient of 60-year-old female presented with recurrent syncope and ultimately diagnosed as a case of sick sinus syndrome. And our second and third case are both elderly patients with degenerative complete heart block. So we implanted permanent pacemaker to all of them, and we implanted the in our first patient, that RV pacing lead in the upper mid septum with the paced QRS duration is about 88 milliseconds, and with the axis is normal, that is antegrade conduction. And our second case, we implanted the pacemaker in the RVOT position with paced QRS duration is 142 milliseconds, which is a little bit wider, and the axis is inferior, that is conduction is antegrade. And in our third case, we implanted the RV pacing lead in the apical position with the paced QRS duration is about 184 milliseconds, and the axis is superior, that is the conduction is retrograde. So the question is there an optimal RV pacing site, and which is better site? Septal, upper, mid or outflow, or apical, or conduction tissue pacing? Actually, several studies have demonstrated that heart failure and atrial fibrillation are the 2 grave consequences of RV apical pacing. And the studies comparing the RV septal pacing to apical pacings are available for more than 2 decades. And the data of several small studies suggest that modest but significant benefit of RVOT pacing over RV apical pacing. But when the larger studies come, that is multicenter clinical trials are come to search for the optimal RV pacing site, like PROTECT PACE study, and the result published 2 hours after follow-up, it was a boom, because they showed there is no significant difference between RV apical versus septal pacing. So it's a model. But the point to be noted that all of these studies relied on the fluoroscopy to determine the lead location, which was not accurate, because fluoroscopically the location of the RV lead seems very close to the right bundle branch. But the reality is validated by this study. They showed validation of conventional fluoroscopic criteria for RV lead position using cardiac CT. They showed only 21% of the presumed septal RV leads were really on the true septum. So the thinking about the site selection was too anatomical, not sufficiently electrophysiological. But the importance of electrophysiological lead position was validated in this study. This is a landmark study, Predict Heart Failure, where they splitted the paced QRS duration of the patients into 3 groups. And after 3 years of follow-up, they showed the ejection fraction was significantly reduced in the group 3, where the paced QRS duration was more than 190 milliseconds. So they summarized paced QRS duration could be an useful predictor to identify the patient who are at risk for heart failure. So the first law of ventricular pacing is the best ventricular myocardial pacing site cannot be as good as ventricular activation through the intact His-Purkinje system. So the optimal pacing site is His bundle pacing, but this is technically very challenging. So what about our cases? In our first case, our paced QRS duration was about only 88 milliseconds. So what does it mean? It means QRS width is determined by how quickly the paced site enters the His-Purkinje system. So in summary, the comparison of anatomically determined RV pacing sites show no meaningful differences. Pacing site should be determined both anatomically and electrophysiologically by pace curious duration and excess. So the ideal RV pacing site is one that quickly engages the maximum His-Purkinje system. And the quality of pacing site is directly proportional to the antegrade conduction of the His-Purkinje mediated ventricular activation. Thank you. Thank you for patience hearing.